So shall I start?
Yeah. So good evening, everyone. I'm Dr. Anil Sachdev and from Gangaram Hospital. And today, our DNB first year, Dr. Ananya, who joined few months back, is going to present an interesting case of asthma. So she is going to tell us about the case and uh, little bit about the asthma because asthma itself is a very big topic, not able to cover up in an hour time. So Ananya, you may start now.
Yes, sir. Here is a patient of 15-year-old male who resides in Delhi, presented to SGRH on 28th of April 2026 with the chief complaints of cough since 15 days, fever since 4 days, and shortness of breath since 1 day. History of presenting illness. The child presented with cough since 15 days, on and off type, initially mild and intermittent, non productive in nature, non spasmodic, no post tussive vomiting, cough more pronounced at night, associated with noisy breathing, sneezing, and nasal block. There is history of seasonal variation, and he also complains of fever, developed 4 days prior to the admission, low to moderate grade, maximum temperature documented 101 degree Fahrenheit, which 2 to 3 spikes per day, not associated with chills or rigors, no diurnal variation, relieved with oral antipyretic medication. He also complains of history of shortness of breath since 1 day, progressive in nature, increased work of breathing, complained of while increased work of breathing while climbing stairs. Negative history. There is no history of ear pain or ear discharge, no history of skin rashes or eczema, no history of mouth breathing or excessive snoring, no history of chest tightness, no history of exposure to known allergen, no contact history of tuberculosis, no history of weight loss or night sweats, no history of hemoptysis, and no history of chest pain. Past history.
Okay, hold on, Ananya, hold on.
Yes. Yes.
So, depending on these few slides, the
Yes.
initial presentation you have said and told us. So,
Yes, sir.
what do you think this child is suffering with? Now, I'm not asking for a specific clinical diagnosis, but I'm
Yes.
just asking you about in general, when you
Yes.
were taking history, what was coming to your mind? That this child has primarily
Cough and fever, sir.
no
Uh,
disease of, he is
is a
possibly suffering with a disease of
respiratory
respiratory
tract.
system,
Yes, yes, sir.
likely lower respiratory, likely a parenchymal disease,
Yes, sir.
right? So,
Yes, sir.
and the second question to you is why you are taking all these negative histories. You can tell us the importance of all these negative histories.
Yes, sir. History of ear pain or ear discharge is to rule out any history of URTA or rule out otitis media, and history of skin rashes or eczema to rule out any atopic triad like in bronchial asthma. There is atopic triad, bronchial asthma, allergic rhinitis, and atopic dermatitis, and no history of mouth breathing and excessive snoring to rule out adenoid history, and history of chest tightness is to rule out complication of asthma, and to
For,
exposure of
for that for that matter, for any parenchymal disease, tightness is a different feeling, which only a
yes,
patient of asthma can feel.
yes, sir.
Right? And this ear discharge is important because if there is a history, no, he is a 15-year-old, but in a small child, if there's a history of ear discharge or recurrent ear discharge, then immunodeficiency is a very, we have to think of primary immunodeficiencies.
Okay, sir.
Similarly, for a patient to skin rashes or ear discharge combination with chest issues, then then you always think of LCH.
Yes, sir.
Okay, then history of tuberculosis is obviously,
Yes, sir.
then weight loss. Why weight loss and night sweats?
Is to rule out tuberculosis
For
because
any
he had
chronic infection. For any chronic infection.
yes, sir.
Hmm.
and to history of hemoptysis, to rule out any bronchiectasis or bronchiectasis history, and no history of chest pain.
Okay. Go ahead.
Past history, at the year of 2016, when he was 6 year old, he had multiple episodes of recurrent cough where he showed to the nearby clinic and had taken symptomatic treatment which was undocumented, and he had not he was asymptomatic for 2 years, and then in the year of 2019 he had similar episodes of recurrent cough. So he went to the private clinic nearby where they had done the pulmonary functions test, and they had started on inhaler corticosteroid. But he was non-compliant. He taken only for 1 year, which was on and off, and lost to follow-up due to COVID. In the year of 2021, similar complaints. He had persistent cough. He went to the different private clinic, and there also they started the inhaler, meter dose inhaler corticosteroid for 1 year, and which he did not continue. He stopped on his own. And in between 2021 and 25, we had no severe symptoms of cough. And then in 2025, he was admitted in SGRS with complaints of abdominal pain and constipation and complaints of cough. Gastro reference was sought and was managed conservatively. In view of cough, on chest findings, an inhaler Foracort 200 microgram BD, 1 puff BD was prescribed, but they did not continue it. And there is a history of taking Ayurveda medication for the above mentioned complaints of abdominal pain, which he mentioned he got relieved after taking that.
Okay, Ananya, one precaution to all the DNPs, including you, that during presentation and during exam, don't mention Foracort. You do not mention the marketing name of brand names.
Yes,
You
sir.
mention, you say the child was put on inhaled corticosteroids with long-acting beta agonist or LABA.
Yes, sir.
Okay, so that's a precaution every DNB should take.
Yes, sir. Birth
Mm.
history, full term, LSES, because of meconium stain, but he cried spontaneously after birth. There was no history of NICU stay. Family history,
Okay,
no.
go back.
Yes, yes, sir.
Now you tell us the importance of each of these factors.
Uh,
You know this child has asthma.
yes, sir.
So what are the risk factors at birth or in the neonatal period in the perinatal period which are associated with the asthma in childhood?
Uh, Meconium stain, if meconium aspiration happens,
Mm.
that can cause into repeated infection, and there can
Okay.
be bronchopulmonary dysplasia.
No, that is a different disease, bro. That is a different spectrum.
Yes, sir.
Mm. So at birth, the risk factors which are associated with as childhood asthma are prematurity.
Yes, sir.
Okay, that
Yes,
is
sir.
early visas. They're under five visas, what we used to call them.
Yes, sir.
So now they are prematurity, low birth weight, meconium stain liquor. All these are important histories one has to take.
Yes, sir.
And of course, if the patient is symptomatic without all these risk factors, but still symptomatic and has a nose block or cough from the early neonatal period and presents to you with wheezing, then we should keep in mind the one of the differential diagnoses of primary ciliary dyskinesia. PCD
Okay.
patients quite often they present early neonatal period.
Yes, sir.
Okay.
Yes, sir. Family history. There was no family history of bronchial asthma, no contact history of tuberculosis. There was a history of allergic rhinitis in father, where he used to take symptomatic treatment levocetirizine, and it used to get relieved on its own. Developmental history, no developmental delay. He had a good scholastic performance, and he was good in academics. Nutrition history, there was no deficient in the nutrition. Immunization history, he was immunized till date as per national immunization schedule. Socioeconomic history, head of the family is grandfather. The number of family members who stayed together are 11. Housing 3 BHK, Pakka house, filtered drinking water they use. There were no history of any indoor plantation, no history of any contact to pet animals or any smoke or any construction work nearby. Uh, Sanitization and hygiene was good. No smoker at the home. Overcrowding was present, and he belongs to lower middle class according to Kupuswamy classification.
So what is the importance of all these features that you have asked?
So the number of family members uh, shows there is a overcrowding in the home, which can cause repeated infection, allergic.
Respiratory infections.
Yes, sir.
Okay.
And indoor
Mm.
history of indoor plantation, moisture, uh, that also can cause infection like fungal infection. History
Mm.
of pet animal is like known allergic trigger like pollen, dust, smoke, pet animals, and smoking like cooking, whether it's normal gas or like cooking by using wood, and by sanitization and hygiene if it's good or not.
So yes, it's very important to take the history of any type of smoke in the house. Whenever you tell the parents what are the sources of smoke in the house, they always think that we are talking about cigarettes.
Yes, sir.
They will never accept that the dhoof agarbatti can also produce the smoke, because
Yes,
that is part of their household. So we have to go into the detail and dig on these questions,
yes,
and
sir.
get a reply on these particular aspects. Second, another thing which you should add in the socioeconomic history is exposure to pigeons, because there are many people are living in flats, the multi-story buildings, or first floor, second floor, fifth floor, and there is always a shaft in the house, and these shafts are housing for pigeons. So
Yes, sir.
they have exposure to pigeons,
Okay, sir. Okay.
right? So
Yes,
we
sir.
have to go into these details, and
Yes,
exposure to cockroaches.
yes, sir.
These are important histories.
Yes, sir.
Hello.
Yes, sir. Uh,
Hanji.
so summary: 15-year-old male born of full-term LSCS delivery belonging to lower middle class Kuppuswamy scale, all developmental milestone achieved normally and fully immunized with no dietary deficiency of calories and proteins. Known case of bronchial asthma, non-compliant to medications, was admitted in our hospital with the chief complaints of non-productive cough associated with rhinitis and history of seasonal variation along with acute onset of low to moderate grade fever without chills and rigors and an increased work of breathing. Differential diagnosis based on the history is my first differential diagnosis is uncontrolled asthma or difficult to treat asthma. Asthma with LRTA, which can be due to bacterial or viral infection, or complicated asthma with suggestive of ABPA or pulmonary TB. General
Ananya, go back. One slide more. Okay, this is the history. No, go further, go further. Next slide, please. Yeah,
yes,
this is a differential diagnosis. You have to justify, give points for and against.
yes, sir. Uncontrolled asthma or difficult to treat asthma is mainly he was not complained. Multiple times he has been prescribed inhaled corticosteroid, but he was not complained throughout his course. And asthma with LRTI is bacterial or viral because cough was associated with fever, which can be a cause of bacterial or viral. And complicated asthma with ABP or pulmonary TB had a chronic cough for 2 weeks. So that can be comes to pulmonary TB. Hello.
Is there any point against the diagnosis of asthma? Forget about difficult asthma or uncontrolled asthma.
Yes, sir. Mm, I don't know, sir.
No. So, what is the definition of asthma?
Asthma is chronic obstructive disorder where there is reversible is caused because of reversible bronchial changes.
No, that is not the definition of asthma. You are giving a pathological or pathophysiological definition of asthma. What is asthma? How do you define asthma?
Sir, asthma asthma is like a obstructive disorder which is characterized by the reversible airway obstruction
Hmm.
and with recurrent episode of cough, chest tightness, breathlessness,
So it is a disease where the cough is dry. It is a non-productive cough,
and
okay,
yes, sir.
with
Airway
variable
hyperresponse.
variable variable expiratory obstruction. It's a disease of expiratory obstruction.
Yes, sir.
Okay, so
Yes,
it's a
sir.
disease of chronic cough with chest tightness, non-productive cough with variable expiratory
Respiratory
obstruction
obstruction.
and with reversibility
Yes, sir.
or response. Reversibility is now changed to responsiveness. Now the reversibility is no more used. Now the term that they use is responsiveness to beta agonist.
Okay, sir.
So there is no doubt about the asthma, but uncontrolled asthma, okay, we'll talk about it later.
Yes, sir.
LRTI, you're saying because he has a history of fever,
Fever.
URI, and all.
Yes, sir.
Yeah. And complicated asthma is because you're saying because it's a long
Cough
history
since
and
2 weeks. Yes, sir.
mm,
Yes, sir.
yeah. So that is a query thing. Right. Go ahead.
General examination on time of admission. The temperature of the patient was 99.4 degree Fahrenheit. Pulse rate was 112, which was regular, normal volume and character. Respiratory rate was 28 cycles per minute, and SpO2 was 93 percentage on room air. Blood pressure was 112 uh, 68 mmHg. There was no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, no pedal edema. Head to examination, skin, no urticaria or eczema. There was no rash. Eyes, no redness, no watery discharge. Nose, there was bilateral nasal cavity, purulent discharge, severe DNS towards the right. Oral examination, grade 2 tonsil, there was good dental hygiene. Neck, there was no palpable lymphadenopathy. Chest, elliptical in shape, bilateral symmetrical. Abdomen, not distended, umbilical central, and no dilated veins. Anthropometry. His weight is 45 kg, height is 160 centimeter, BMI is 18, which is between 15 to 25th centile. Systemic examination.
So you said that he had good nutrition. There was no deficit in nutrition, but his height and weight both are below 50th centile.
Yes, sir.
Below 50th centile. What is the explanation for that? Do you have any explanation for that?
No, sir.
No. So
Height can be constituted.
yeah,
Height.
usually asthma patients are not deficit. They don't have growth deficit. But if they have associated chronic infections,
Yes, sir.
particularly ABPA, or when they develop bronchiectasis because of the chronic infection, or because of ABPA, or because of tuberculosis, particularly in Indian scenario, then there can be a possibility. So if there may be a uh, discrepancy in the nutrition, you have been told, and that may always explain. So this is quite a significant growth retardation, no?
Yes, sir.
Mm. Go ahead.
Systemic examination. RS examination. Inspection. Chest shape was elliptical and symmetrical. Chest movement is reduced bilateral. Tachypnea was present. Prolonged expiratory phase. Use of accessory muscle present. No chest wall deformity, scars, or sinuses. Palpation. Trachea felt to be in the midline. Movement with respiration. Chest expansion is symmetrical on both sides. No intercostal tenderness. Vocal fremitus normal. Chest circumference on inspiration 84 centimeter and on expiration 78.5 centimeter. RS examination on percussion was resonant in supraclavicular, infraclavicular, mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular region.
Can you go back to the previous slide, please?
Yes, sir.
Chest circumference. What do you expect in patients of asthma?
Yes, sir. Uh,
What do you expect in patients of asthma? What type of chest deformity, types of deformity do they get? Hmm?
they will have because of they can barrel shaped chest.
Barrel shaped sets. That is
Uh,
because of
increased
chronic expiratory
air
obstruction.
because of
They
air
are they have air trapping. So
sir.
that is why their anteroposterior diameter increases.
Yes, sir.
That is why there is a barrel shaped chest.
Yes, sir.
And the difference between this is 84 and 78. It is almost 5.5 centimeter. I think
Yes,
this is more. So there may be some air trapping happening at this stage because of the chronicity.
yes, sir.
Possibly, yes. Okay, go ahead.
Percussion felt resonance
You
in
said,
all
yeah,
the
yeah. Go ahead.
auscultation, normal vesicular breath sound heard in all the areas. There was bilateral air entry was present. Expiratory wheeze present on bilateral diffuse lung fields. There was no Krebs. Other systemic examination, cardiovascular system, S1, S2 heard, no murmur, abdomen soft, not distended, liver and spleen are not palpable, CNS conscious oriented, no focal neurological deficit, there is no meningeal signs.
Okay, particularly in obstructive airway disease or any chronic respiratory disease, during examination, don't just forget to say P2 not loud or P2 normal. because whenever you have P2 loud, it indicates there is a chronicity of pulmonary system. So there
Yes.
can be a possibility in particularly in an adolescent child, it is very important. So
Yes, sir.
particularly mention that there are P2 is normal
Yes,
because
sir.
loud P2 is indicative of
Pulmonary hypertension.
pulmonary hypertension or core pulmonary for that matter. I'm not saying particularly in asthma, but in
Yes,
any respiratory case, you should always speak that the P2 is normal.
yes, sir.
Mm.
Summary: 15-year-old male child born with full-term LSCS delivery belonging to lower middle class Kupus-Kwame scale. All developmental milestone achieved normally, fully immunized with no dietary deficiency in calories and protein, and known case of bronchial asthma, was admitted to our hospital with chief complaints of cough, fever, and increased work of breathing associated with noisy breathing. On examination, the child was tachypnic with intercostal retraction and bilateral expiratory wheeze was present.
What is your diagnosis now? Okay.
Un- Uncontrolled bronchial asthma presenting with acute exacerbation is
So
my professional.
what are the causes of uncontrolled asthma?
One is non-compliance
Non-compliant to?
to the medication,
Mm.
and uh, the usage of not usage of MDI spacer, and not proper technique.
So uncontrolled bronchial asthma.
Yes, sir.
So
Uh,
what are the causes? This is very important. If you do not recognize those features which are responsible for uncontrolled asthma, then how will you treat this child?
yes, sir. Like, not compliance is one thing, and one more thing is no proper technique usage,
Yeah.
and other like environmental triggers around by
Mm.
uh, dust, pollen,
Mm.
and recurrent viral infection that can cause even more complication.
Mm. So that is overcrowding.
Yes, sir.
This child has overcrowding.
Yes, sir.
So there are many factors which are responsible for uncontrolled asthma in this child. First is non-compliance. So many times he started and he stopped treatment. Then second is inhalation technique. Whenever a patient like this comes to the clinic or in the hospital in the OPD, we have to uh, ensure that the inhalation technique is correct. We just don't assume that we have told the patient on the last visit that is how it is. He's going to, must be taking his medications properly. We should not assume. Every time they come, we always ask them to bring their inhalation devices, and then we go ahead and always get a demonstration done or ensure that the technique is correct.
Yes, sir.
Okay, many times they just especially for the MDI they just keep on using it the empty canister. They do not now the most of the MDIs are with counter dose counter. But previously when the counters were not available, those counters were not available, then they just continued because some bit of gas, the carrier gas of vehicle gas used to be there. So ensuring the adherence, ensuring the technique, then you said overcrowding. So these are the environmental factors. Then what else? Exposure to allergens, indoor or
Allergen.
outdoor allergens.
Yes, sir.
Then
Um,
always look for comorbidities. So what are the comorbidities which are associated with asthma?
uh, like viral infections
That is
he
not
had.
comorbid. That comes with the overcrowding. No?
Yes, sir.
Uh,
He had allergic rhinitis and
yes,
in
this
his
is
flex.
allergic rhinitis, as you said,
Yes, sir.
deviated nasal septum, as you said.
Yes, sir.
Okay, then second, another atopic dermatitis,
Atopic dermatitis.
allergic conjunctivitis, adenoidal hypertrophy.
Yes, sir.
Okay,
Uh,
so whenever you are treating these patients, you have to treat all these features, all these associated problems. Then only your patient will respond to treatment of asthma. Always you have to see for the overweight or the obesity.
Obstructive sleep apnea.
That's a very, very important comorbidity.
Yes, sir.
So all these comorbidities you have to take into account. Rhinosinusitis, atopic dermatitis, allergic conjunctivitis, then obesity, even smoking in the house, any type of smoke exposure. In Indian families, especially Hindus, the havans are very common. They do havan at home.
Yes.
So that's very common. So all these things need to be considered before you label this child. Okay, there everything is clear. So I have to modify my treatment. I have to step up my treatment. So every time a child comes to you, you don't go into the history and details of these issues and you just increase the dose of inhaled corticosteroids. That is not going to help you.
Yes, sir.
Okay.
Yes, sir.
Hmm. So why did you write acute exhilaration? Was this child in actual acute exhilaration?
Uh, no, sir, but he had 1 day history of increased work of breathing.
That
So,
can be because of asthma only, no?
yes, sir.
Or there may be, what is the classification of acute exhilaration? Mild, moderate, severe.
Mild. Mm,
Read about it.
yes, sir.
Okay, go
Yes, sir.
ahead.
Investigations. His hemoglobin was 15, TLC was 12,000, DLC neutrophilic picture 82, and lymphocyte were 11. Absolute eosinophilic count was 126. Absolute neutrophilic count was 10,348. ABPA panel was sent. Total IG was 1,300.
Hello, 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 Ananya, Ananya, Ananya. Your voice is cut. We can't hear you.
Yes, sir. I'm joining in.
सर कोई नेटवर्क इशू है उनके यहाँ पे अभी 1-2 मिनट में वो लॉग इन कर रही है।
Sorry, sir.
Yeah. Go back to the blood investigation. Start from there.
Yes, sir.
Yeah.
Investigation.
Hmm.
Uh, his his hemoglobin was 15. Total leukocyte count was 12.62. Differential leukocyte count neutrophilic picture was 82. Lymphocyte was 11. Absolute eosinophilic count was 126.2. Absolute neutrophilic count was 10,348. ABPA panel, total IG was 1985. Aspergillus specific IgE was 5.05. Aspergillus fumigatus specific IgG was 28.10. Atopic screening test Fadetov was 9.27. Respiratory biofile came positive for human rhinoenterovirus.
So, what is your interpretation of these investigations?
Uh, the main asthma which aggregated first main because of viral infection,
Hmm.
and his total IG was raised, and ABPA panel showed Aspergillus specific IgG is also raised, so can be because of Aspergillus pul- in Aspergillus infection, fumigatus infection.
Hmm. And
But
what about Fadiatop?
Fadiotop is a little contradictory thing.
Why?
Like in atopic screening test, Fadiotop, usually Aspergillus is not included in this, but
Yeah.
this is raised.
So,
Um,
why it is contradictory? Why it is contradictory?
mm,
Actually, at topic, this Fadiatop screening includes house dust mite and few fungi, but not
cockroach.
Aspergillus,
Yes, sir.
and the cockroach is not there. So mainly the SDM. HDM means house dust mite.
Yes,
So
sir.
this child may be originally sensitized to house dust mite. That is why Fadiatop is significantly positive, and he has now acquired. He is sensitized to now Aspergillus also.
Yes,
It
sir.
is very much possible. We have to go in for further testing, especially in such a case we should go for the skin prick testing.
Yes, sir.
Hmm. So
Test
this
X-ray.
yeah, go ahead. Stay.
It is a PA view
Hmm.
and showing increased bronchovascular marking, hard
Hmm.
borders are visible, and hyperinflation of the lungs are seen.
Hmm.
Trachea is central.
Hmm. Any other feature? Any other feature of hyperinflation? What are the features of hyperinflation in this?
Increased lung fields.
Hmm.
2, 3.
What are the features of hyperinflation?
The lung looks more
More,
lucent, uh, radiolucent.
well, they're more dark. Okay.
Yes, sir. Yes, sir.
In simple words, they are looking more dark.
Yes, sir.
Then second, and third.
Second,
Diaphragm. Look at the diaphragm. Hello.
and hello.
Diaphragm.
Uh,
How the
uh,
you see the
flat.
diaphragms?
Yes, sir.
They are flat.
Diaphragm flattened, sir.
Yeah, diaphragms are flat. The dome is gone.
Yes, sir.
And
And
how many intercostal
increase
spaces?
number of anterior and posterior ribs.
What is that? One, two, three, four, five,
8.
6, 7, 8, almost 8 on the right side. So, how do we define hyperinflation?
When there is more than 8 ribs.
8 or more than 8, right? Sometimes some people say 9 also. There's
Yes,
one
sir.
more feature.
Tubular heart disease.
Yes, very important. Heart looks small.
Yes, sir.
So these are the four features here.
Yes, sir.
Okay, bronchovascular marking is a very, very non-specific thing. It is not at all suggestive of obstructive airway disease at all.
Yes, sir.
Okay. What next you will do?
Uh, HRCT.
Why?
It is to look for any parenchymal changes.
Hmm. In view of in view of
Hyperinflated lung fields.
no. In view of
AB, uh,
yes. In view of
ABPA,
ABP. Yes.
ABPA picture.
Sensitization.
Sensitization. Yes, sir.
Sensitization.
Yes, sir.
Aspergillus sensitization.
Yes, sir.
Okay. ABP is a disease. Aspergillus sensitization. You still not sure whether it is disease or it is just a sensitization.
Yes, sir. So here, it reveals bilateral lung mosaic crack.
What type of window is this?
This is bone.
In CT scan, you see one. Some frames are more dark. Some frames are like that, like this. So what is this? This is what is this? Yeah. You
This
have
is
one more frame. Go to the next frame. Next slide. Oh, you have removed that. Okay. So there are two windows. What
bone
window is
window.
this?
Uh,
What window is this? This is lung window.
is
When you want to look at the
lung
parenchyma, then you look for lung window. When you are concentrating on the heart or the other mediastinal structures, then we look at the when we look
lungs.
at the
Lung windows.
mediastinal window. This is lung window where you can see the lung parenchyma. I think you are gone again. Nanya, Gaurav, Gaurav, Gaurav.
हेलो।
हाँ जी,
सर मैं
क्या
बात
हो
कर
गया?
रहा हूँ डॉक्टर से, उनको फोन कर रहा हूँ दोबारा। मुझे लग रहा है उनके है ना नेटवर्क सिग्नल का सर इशू चल रहा है थोड़ा सा। मैं दोबारा बात करता हूँ।
Hello.
Yeah, go ahead.
Yes, sir. So, in this HRCT, we see mosaic pattern with eight wrapping and with bronchial wall thickening and mucus plug secretions.
Can you pinpoint to that?
Yes, sir. Mucus plug secretion
Yeah,
and eight wrapping, we can see the difference. Here
yeah,
it is dark and
yeah.
here it is comparatively lighter.
Hmm. And
And mosaic pattern can be seen.
so this is whatever you're explaining is making the mosaic pattern, no?
Yes, sir.
Hmm. And
And bronchial wall thickening with the mucus
yes,
plug.
okay. Is there bronchiectasis?
In this, it's not seen, sir.
What is this where you are pointing out? What is this? There's a long streak going towards the periphery. Yeah,
Uh,
this one.
bronchiectasis changes.
No, this is not bronchiectasis. This is not bronchiectasis. This is
Control.
possibly segmental atelectasis or it's a fibrotic band.
Yes, sir.
No, this is not bronchiectasis. The bronchial wall thickening evidently seen as you have pointed out. And on the left side, as you can see, the signet ring type of thing.
Yes, sir.
Yeah, these one. So these one also the bronchial. This is a cross-sectional view, and the other one is the along the length of the bronchus, and there is a retention of the secretions.
Yes, sir.
Okay, the bronchiectasis is not yet evolved, but likely to evolve. Looking at all these changes, right? Go ahead.
Yes, sir.
Next slide, Anya.
HRCT report.
Okay, you have so said that. Okay, go
Yes,
ahead.
sir. So we had done the impulse oscillometry in this patient to look for the bronchodilator response. Uh, in this lighter color shows the pre-bronchodilator and the darker color shows the post-bronchodilator effect. So at the 5 hertz region, there is a increased amplitude, which shows that small airways are responding to the bronchodilators, which is suggestive of small airway obstructive disease, where there is reversibility post bronchodilators.
So let me tell all the DNB students here that oscillometry is not the standard investigation for judging the obstructive airway. Pulmonary function, that is spirometry, is the standardized thing. It's a validated and standardized tool. So in exam, don't say oscillometry as a first, but if the examiner asks you how will you assess the reversibility or responsiveness to bronchodilator, so please say spirometry. Don't say oscillometry.
Yes, sir.
Oscillometry is yet not a standard investigation or for the asthma patients, right? But
Yes,
as
sir.
she has rightly said, at 5 hertz, that is sound waves, there is a reversibility. So it's a pure small airway disease. So this is another talk. It's impulse oscillometry or oscillometry is different talk. So we'll not go into these details. Okay, go ahead. Go ahead.
Bronch-
Yeah.
we had done the bronchoscopy on 4th,
Mm.
which showed cell count 85 per and cells was 1000. Corrected TLC was 83. pH was alkaline. Cell type neutrophilic picture was 64 percentage. Lymphocytic picture 36 percentage. Absolute eosinophilic count was 0. And the gram stain was negative. TB gene expert MTB was not detected. KOH fungus was negative. Galactomana and Aspergillus is yet to come.
Why the bronchoscopy was done? Asthma patient don't need a bronchoscopy.
Yes,
Then why it was done?
to
To
look for the Aspergillus.
Mm. So you already said that this in CT scan there was evidence of retained secretions, okay, bronchial secretions.
Yes, sir.
So it is very important to do the lavage and see for any tuberculosis or any CT doesn't differentiate, will not tell you everything about tuberculosis or ABPA. We already know that the child is sensitized to aspergillus, but the CT scan is showing retention of secretion of the bronchial secretions, fluid-filled bronchi. So important to rule out secondary infections and to rule out tuberculosis. And if the QH comes positive, then it becomes a case of invasive aspergillosis. So when you grow aspergillus from the ball in a case like this, so then it becomes a case of invasive bronchitis. The treatment becomes a little more, it's a different type of treatment. So that is why it is important to do bronchoscopy and lavage in these patients.
Yes, sir.
Okay, go ahead.
So, asthma is a chronic inflammatory airway disease, which is characterized by reversible flow obstruction and airway hyperresponsiveness. Treatment of asthma in this child, GINA guidelines 2025, as he is 15-year-old. So, based on adjust, review, assess method, there are two tracks, track 1 and track 2. Track 1 is usually the preferred one, where in step 1 and track 1 is more we preferred one, as we use inhaled corticosteroid formoterol is used both as a controller and reliever. In step 1 and 2, we use low dose of inhaled corticosteroid with formoterol. In step 3, low dose as smart maintenance therapy. And step 4, we use medium dose maintenance inhaled corticosteroid. And in step 5, we add LAMA and biologics like anti-IG and anti-IL-5, anti-IL-4.
So this is at every step. you have to go back. You can see a circle on the top, review,
Yes, sir.
assess, adjust. So this
Adjust.
circle has to be followed on each visit.
Yes, sir.
On each visit, you always have to go look at these, the treatment, non-pharmacological studies, asthma medication, including ICS, education and training of the patient, confirmation of diagnosis. Whenever the patient is not responding, always go into the modifiable risk factors like comorbidities, inhaler techniques, adherence. That's what we have already talked about. And the patient and the parent given preferences and the goal. If they are not happy with the MDI, you give them an alternative. So it's always, and as far as the review is concerned, you always go into the details. Why the exhibitions? Why are there any side effects? Are there any comorbidities? What are the lung functions at this moment? And consider the biomarkers if you want to do. What are the biomarkers?
IG, IgE,
IG,
IgE, IL-5.
fractional excretion of nitric oxide. That is a biomarker for this. All these guidelines are revised every year. GINA 26 released this week only, recently in May. So GINA 26 is available on the net now. So this is a different now, but okay. Then anything else you want to tell us now, Ananya?
There are so based on the methods, if the patient is responding well and if suppose the patient is in step 3 treatment and is responding well, we step down to step 1 and 2.
After how much time?
Uh, I,
That is important. You see, if the patient comes to you on, you give step 3, after 2 weeks, he comes back, he says, I am all right, I have no symptoms. Will you bring down to step 1 too?
no,
No
sir.
change for 3 months.
Yes, sir.
So he has to continue step 3 treatment at least for 3 months.
Okay, sir.
Go to next slide now.
Uh, what is
Okay.
uncontrolled asthma,
Hmm.
difficult to treat asthma, and severe asthma? Uncontrolled asthma is the patient who has poor symptom control, who has frequent symptom, activity limited by asthma because of asthma symptoms, and night walking due to asthma. And if there is frequent exacerbation of more than 2 episodes per year, that requires him or her to have oral corticosteroid, or severe exacerbation more than 1 episode per year, which requires hospitalization. Difficult to treat asthma, that is uncontrolled despite prescribing medium or high dose inhaled corticosteroid with second controller, or with maintenance oral corticosteroids. Severe asthma is a subset of difficult to treat asthma, where asthma is uncontrolled despite good adherence to the optimized high dose of inhaled corticosteroid LABA treatment. And it is also called as severe refractory asthma.
Hmm. So severe asthma is a subset of uncontrolled asthma
Yes, sir.
or difficult to control asthma, right?
Yes, sir.
Okay, go ahead.
So, asthma and ABPA correlation. If any asthma which is poorly controlled, and if there is recurrent exacerbation with elevated IgE, with elevated eosinophilic count, we have to suspect ABPA. Diagnostic feature of ABPA: uncontrolled asthma with total Ig of more than 1000 international unit per ml, Aspergillus specific Ig increased with peripheral eosinophilia with central bronchiectasis changes on HRCT. The stage-wise management of patients with ABPA. Any patient who are newly diagnosed with ABPA, we should start with oral glucocorticoids or itraconazole for 4 months, and we have to follow up with spirometry and serum total Ig and chest X-rays, radiographs, and we have to look for the response. If the patient is stable for 6 months, the patient will be in remission. If not, then we have to start oral glucocorticoids or itraconazole for 4 months with frequent oral glucocorticoids and itraconazoles for 4 months. And then treatment dependent ABPA is with oral azoles, anti-type 2 biological agents, or nebulized amphotericin or low dose of glucocorticoids. Management of ABPA is mainly with oral corticosteroids, itraconazole, antifungal therapy, and to optimize the asthma control. So this patient comes under ABPA B criteria. So based on the HRCT finding, if there is no bronchiectasis, only serological test will be positive, then it is categorized as ABPA-S. And if the patient is having bronchiectasis changes, it is categorized as ABPA-B. And if the patient is having mucus plugs in the HRCT finding, it is categorized as ABPA-MP. And if the patient is having uh, central uh, and here in our patient, the patient had child history of asthma with sensitization of Aspergillus fumigatus IG, where total IG was 1985 with increased eosinophila and Aspergillus IgG, and here suggestive of ABPA B bronchiectasis changes.
This is not exactly bronchiectasis, but yes, the where the we could see the thickening of the bronchial wall, it is all central and likely to. How do you say that the bronchiectasis is there?
Based on the
The size,
HRCT finding.
HRCT finding, but there is criteria that the size of the bronchi and the pulmonary vessel, pulmonary artery. The pulmonary artery is bigger than the bronchi. So when the bronchi becomes equal or rather more than the diameter of the pulmonary artery, then it is bronchiectasis. Okay, that has yet not happened in our patient, but yes, we have to treat him for asthma and ABPA. Okay, next. Thank you. So, any questions in the chat box? Mm, Nobody has written any questions. Okay, you can unshare, Ananya.
Yes, sir. Thank you, sir.
So this was a case of childhood asthma who has now gone into the complication of ABPA. So we have to treat both, but very important is as they were missing the treatment for so many times, so we have to ensure that they don't miss the treatment and child, if we can save the child from going into bronchiectasis complication, that would be good. Okay. If there are no questions in the chat box, no queries, then good night to everyone.
Good night.